In 2015, world leaders committed to providing quality health services to everyone by 2030. We have less than 10 years to reach the goal of universal health coverage, and yet over half the world still lacks access to essential primary health care. As a consequence, 930 million people are at risk of falling into poverty due to out-of-pocket spending on their health needs. Digital technologies hold the potential of accelerating progress to health for all. Effectively deployed, digital technologies can strengthen health systems, support individuals to better manage their own health, and enhance the availability, accessibility, affordability, and quality of health services. Digital Health Week is a global moment to champion the role of digital health in universal health coverage. During Digital Health Week, organizations around the world are coming together to host events, make public commitments, and shine a light on the successes and challenges of digital health and UHC in their contexts. During Digital Health Week, civil society, private companies, government health ministries, and interested individuals are discussing the challenges and opportunities for digital health in their countries and regions. How far has digital health come? What barriers must still be overcome?
Our work on improving HIV rights and sexual and reproductive health and rights in Kenya, it is no longer possible to ignore the potential that digital health holds in improving access to health services and realizing the right to health.
Geographic, or the Indonesian Public Health Association, commits to working for the goal of universal health coverage through our 35,000 members. The time to champion digital technologies in achieving health for all is now, and we will be hosting the 7th annual Public Health Scientific Conference in Geographic and bring together leaders from across Indonesia and promote digital health.
As we build a digitally enabled future, it's imperative that the voices of young people are not left out of the design, planning, and implementation of these interventions. Digital Health Week is an exciting opportunity for young people to showcase their digital health solutions, as we will be doing through the Humans of Digital Health campaign by Young4H.
The first Global Digital Health Week is being coordinated by Transform Health. We are a coalition of organizations committed to championing the role of digital technology and data to achieve universal health coverage by 2030.
We want to see the transformation of health systems to ensure that everyone has access to equitable, affordable, and quality healthcare by harnessing the potential of digital technologies whilst ensuring no one is left behind. This requires stronger political will, a clear health data governance framework grounded in human rights and equity, and increased and coordinated investments towards digital health.
So join us during Digital Health Week to champion health for all in the digital age. Hold discussions, make commitments, and amplify the role of digital health on your organization's website and on social media.
Welcome to Digital Health Week. Actually, this is a series of activities co-sponsored by the Asia eHealth Information Network with the Transform Health Group and locally with the Philippine Society for Digital Health. So this is actually related to a joint administrative order that was released last April 21, 2021, followed by a memorandum circular on April 23, 2021 on the mandatory adoption and use of national health data standards. You can actually download these files at bit.ly/mandatory adoption. Now, something about the Philippine Society for Digital Health. We are a group of doctors and IT professionals. When we formed this and had it registered with the Securities and Exchange Commission, our vision was to grow and nurture a collaborative Philippine digital health community that encourages and supports national initiatives towards improving health for all. We set for ourselves a mission to advance digital health adoption by fostering innovations and scientific exchange, by educating professionals and the public, and by influencing policymaking on the ethical use of health information. Our core promise and values are to bridge the digital divide towards health for all. In the Philippines, we already passed the Universal Healthcare Act, but we need to operationalize that, and we think that information technology has an important role there. Our values are openness, where we strive to make all our community proceeds open and publicly accessible. Patient-centeredness, where we will keep our eyes focused on the needs of our patients. Collaboration, where we work collectively to prioritize and address the real-world needs of our community's participants. And relevance, where we aim to address the needs of the majority of Filipinos, especially the underserved. This is an extract from the WHO ITU National eHealth Strategy Toolkit. And in figure 5 of the toolkit, the cover page is what you see on the right upper corner. They propose a certain governance structure for e-health, and now we call it digital health, where at the top, there is the health sector leadership provided by the Ministry of Health, and below it would be a steering committee, which is multi-sectoral in the Philippines, and supporting this steering committee would be an e-health strategy team. On the left side would be the stakeholder reference and expert advisory groups. These are people who are well versed in clinical medicine, public health, informatics, and they would be advising the e-health strategy team. And on the right side would be the broader stakeholder environment, essentially everyone who will be affected or supported or benefited by digital health. And that's where we wish to position the Philippine Society for Digital Health. Let me just pause for a while. Thank you. So, starting October 2021, we'd like to inform you that the Philippine Society for Digital Health will now be the home of the Philippine Medical Informatics Society. In 1996, the Philippine Medical Informatics Society was created at the University of the Philippines, Manila, and by the year 2000, it was recognized as the national member for the Philippines in the International Medical Informatics Association. So today, we'd like to announce that the PSDH will now be the home of the Philippine Medical Informatics Society, or PMIS. So let's look at the Joint Administrative Order. The subject is mandatory adoption and use of national health data standards for interoperability. And the global experience with standards development is that it's actually like a dance where you have one person saying that these are the standards and another person following the standards. So in effect, standards are only useful if one, there are standards that are given, and two, if there are standards that are followed. So at the Philippine Society for Digital Health, AHIN, and Transform Health, we'd like to use this opportunity to tell the broader stakeholder environment, the groups like us, what are these standards so that we can understand what they are all about and start following the standards. And once we start following these standards, we will be able to reap the benefits of standardization, interoperability, and of course, later on, universal health coverage. The objectives of the Joint Admissive Order is to define the national health data standards and institutionalize the mandatory adoption and use of national health data standards for interoperability. So in this memorandum circular, you will be able to see the core sets of terminologies, their definitions, and structures for data and report processing, sharing, and exchange. These standards will develop a reference for market development for e-health services, products, systems, applications, networks, and technologies, for example, hospital information systems and electronic medical records. It will define the implementation governance to direct and coordinate the adoption and use of national health data standards, ensure alignment with national health system goals, enable health systems integration, promote awareness and engagement of stakeholders, and support and empower the needed change, implementation, and monitoring of results for delivery of expected benefits. The scope is basically the whole country, including the Bangsamoro Autonomous Region for Muslim Mindanao. So this is the coverage of our standards. So essentially, all health facilities and insurance companies and entities working in the health sector will be covered by this memorandum circular. I won't go through all of the terms, but just want to emphasize a few important ones. In the memorandum circular, implementers are defined as healthcare providers, including community-based healthcare organizations, healthcare professionals, health facility, laboratories and diagnostic clinics, pharmacies or drug outlets, and temporary treatment and monitoring facilities, local isolation, and general treatment areas. So it's a very wide definition of implementers, combination of people and institutions. It also defines health-related entities such as municipal, city, regional, and provincial health offices, academic and research institutions, civil society organizations like the Philippine Society for Digital Health, medical societies like PMA, the Philippine College of Surgeons, health professional associations, non-government organizations, donor or funding agencies, development partners, essentially the other sectors. They might not be directly supporting the Department of Health, but they are actually related to healthcare. And the third group are the insurers. And this refers, of course, to the National Health Insurance Program, which is PhilHealth, health maintenance organizations, and private health insurance companies that have been issued certificates of authority by the Insurance Commission. Then it goes on to define the National Health Data Category Standards, which are the classifications, for example, disease surveillance and response. Another category would be primary care benefit package. Another category would be specific public health programs, etc. And the third component is the National Health Data Dictionary. So in the National Health Data Standards, if you go through the specification, it has different elements that are part of the standard. For example, the data element, the definition of that data element, the source of the definition, the frequency of the update, the data type, data format, the possible values of acceptable answers to the data element, and that would include the standard data code, the standard data code description, the version, the license, the UR link, and the standard data code custodian. So you can contact this group if you want to understand more about the standard and the status of the implementation. the basis of the status, specifically the legal basis and the source of the status, whether it's national legislation, administrative issuance, or guidelines. And the data system application, referring to the name of the information system or data collection reporting forms or their equivalent where the data can be sourced or found. Okay. Release 01 refers to the initial list of mandatory national health data standards, and I'll go to the list later on. And letter F would be the terminology service, referring to an authoritative database for managing unique identification of health services and activities, including standard health and health-related data elements. Then we go through a long list of general guidelines. I won't go through them anymore, one by one. I would like to emphasize the implementation governance. And here, similar to the WHO ITU National Health Strategy Toolkit, we would have the top level National E-Health Governance Steering Committee, which is chaired by the Secretary of Health and co-chaired by the Secretary of ICT. Below them would be the National E-Health Technical Working Group, or TWG, which is chaired by Dr. Eric Tayag from the Knowledge Management Information Technology Service of DOH, and supported by all the other directors or undersecretaries from the other ministries like the ICT, DOST, PhilHealth, and UP Manila. And then below them would be the National E-Health Program Management Office at the Department of Health, KMITS. These are the young people who are making sure that all the day-to-day matters are taken care of. So please don't forget that there are at least 3 layers at the top level: the steering committee, and then the technical working group, and then the PMO. Okay. So now we'll go to the list of the data standards, which, if used by everyone, would be enablers for interoperability. At the second last line of this slide, you will see a website, a web address, www.nhdd.doh.gov.ph. So when you go to that website, you can register for an account, and that will give you access to the National Health Data Dictionary, which is the electronic form of the content in this circular. Okay. Now, the circular also mentions a mechanism for monitoring and evaluating the standards. It's going to be a living set of standards that will be constantly evaluated so that any improvements or any gaps are filled in for the needs of the health sector. Some roles and responsibilities: DOH and PhilHealth will be the one setting and approving these national health data standards. They will provide policy directions and oversight. They will provide the necessary resources to support the mandatory adoption. They will provide technical assistance and guidance. And they will establish coordination and networking with the other partners in other sectors. And they will distribute, disseminate, and publish the approved mandatory national health data standards. So in effect, the PSDH is supporting the Department of Health by creating events like this, where we are able to help them disseminate the standards to a wider swath of stakeholders. There are then there's the Interagency National E-Health Technical Working Group. They report to the steering committee. They recommend policies and implementation strategies. They assist the DOH and PhilHealth in planning and implementation. And then there are the reference groups, the National Health Data Standards Sub-Working Group that review and recommend the National Health Data Standards, conduct the necessary consultations and coordination with all concerned stakeholders, conducts research to facilitate application of emerging health data standards and support capacity building initiatives, and lead the assessment and monitoring of progress status of adoption and use of these standards for interoperability. Now, I think most of us will be in the implementers. We need to understand what these standards are all about, comply with the adoption, and the use of these mandatory health data standards ensure the availability of necessary support to understand, adopt, and implement these standards in our internal systems, ensure the integrity, security, and confidentiality of the health and health-related data that we are collecting and maintaining, to report issues, concerns, and problems that may arise, and provide relevant inputs and feedback to further improve the adoption and implementation of national health data standards for interoperability. So here is Annex A of the circular, and here you will see the formulation, adoption, and use of monitoring, evaluation, and updating of the national health data standards. So essentially, this is a process or a protocol by which standards can be added, deleted, or modified in the national health data standards. So here you can see there are many ways that you can input. It can be a relevant international, national, or national sectoral policies and guidelines. It could be development work from standard development organizations, local or international. It can be from emerging ICT trends and innovations on data standards. It could be health sector directions and needs, or it could be action requests or existing national health data standards that are due for evaluation. And they set 2 years for the regular evaluation of these health data standards. Later on, Dr. Hari Hamoy will share one such input where they gathered stakeholders together on a particular domain and help each other come up with a consensus on a particular standard in that domain. Now, when you do that, when you've come up with your proposed standard, there is still a process in the middle where you submit that through the Management Information Technology Service, and can they have an internal process on how these standards will be evaluated until they are accepted or returned back to the proponent for revision or rejected. So in chapter 2, they exposed the Citizens Charter for action requests. It's very, very detailed, detailing the client steps and the agency actions. I will not go through them one by one, except that the commitment of the circular is that if there is an action request and there is no appeal, the total processing time would be 25 days and 2 hours, very exact. And if there is an appeal, including the appeal process, it will take 45 days, 2 hours, and 5 minutes from the time the request was submitted. So we are looking forward to this total processing time. I think this is a very good inclusion in the circular because it gives clarity on how fast these standards can be accepted, processed, and then published. So what's going to follow are details of these, some elements of the mandatory health data standards. Very prominent here are the data elements related to the person. And this is categorized as master person data. And foremost amongst this master person data would be the patient's PhilHealth identification number. Second would be the PhilSys number. As you all know, the Philippine Statistical Authority has started issuing the PhilSys number. So if you have not yet gotten that, there are stations. I've seen some in the malls. Of course, you can go to PSA where you can obtain your PhilSys number. Other than that, there could be the taxpayer identification number, passport number, or PWD identification number. Together with the PWD identification number would be the type of disability. There's also the Pantawid Pamilya identification number, the senior citizen identification number, pictures, biometrics, and other physical features. So these are all the data elements related to the master person data. For the health facility or consulta provider, there would be the health facility, the active as the date of the consultation, and the civil status of the client. Of course, there would be the last name, the first name, middle name, and suffix or extension name. In the membership general category, if the person is a dependent, then it would have a dependent member's PhilHealth identification number, which is available from PhilHealth, and the relationship to the member, whether it is a child, parent, or spouse. The member's maiden name from PhilHealth member would be the last name, first name, middle name. Same with the spouse, mother's maiden name, father's name, and place of birth. Then there are standard data code sets in the mandatory adoption. We are all familiar with the ICD-10 version 2013, and there's a Philippine ICD-10 modification, which was published in May 2014. So that is the standard that we use in the Philippines right now. Those are the ICD-10 codes that are needed when you file an electronic claims to PhilHealth and to report to DOH. It is used for statistical reporting on major diagnosis, mortality and morbidity, and billing, reimbursement, and resource allocation. The other standard, which is very important, is the client identifier. As I've mentioned, this is the PhilHealth identification number, and this is issued by PhilHealth, the owner and manager of the National Health Insurance Program. They use this for identifying eligibility, for verifying, and to monitor utilization recording. Then there are the clinical health terminology. And here, the memorandum circular puts SNOMED, or systematized nomenclature of medicine clinical terms. It's an international standard maintained by the International Health Terminology Standards Development Organization, or ITSIDU. And when you go to the ITSIDU website, you can see the details of the SNOMED CT. It's very granular, very specific. You can use it for clinical care, and you can use it for clinical research, and you can roll up and roll down, and even use it for population analytics. For the date and time, ISO 8601 is a long-standing standard. It represents a specific way of presenting the dates. So if you're buying an electronic medical record or hospital information system, you might want to ask them if they are ISO 8601 compliant. This is easy to comply with. For drug classification and dosing, there's the ATC DDD, or defined daily dose. You can get this from WHO. It's a set of drugs and drug usage that you can use for documenting the drugs that you use in your EMR or hospital information system. Then there's the Philippines only drug establishment identifier. You can get this. This is issued by the Department of Health, Food and Drug Association. The geographic areas of the Philippines are published as a standard by the Philippine Statistics Authority. It's called the Philippine Standard Geographic Code. The version that is official is version 2015. It goes down to the barangay level. And I think this is now being commonly used right now in the vaccination tracking of the country. For the healthcare professional identifier, the Professional Regulation Commission, or PRC, is the ID that we are using for this. And the registry of all health professionals are maintained at the National Database of Human Resources for Health Information System, or NDHRHIS. So the DOH would be the source of this healthcare. The PRC would be the source of this healthcare professional identifier, and these are collated and consolidated in the NDHRHIS. For health establishment identifier, we will be using Global Standards 1 or GS1. This is accessible and available from Department of Health, Food and Drug Association. For health facility identifier, the source is DOH again. They have the National Health Facility Registry or NHFR. This is available at nhfr.doh.gov.ph, and this is where all the health facilities are listed with their unique identifiers and attributes like location, geographic code, who is the director, and what level of care you can get from those facilities. For health products and devices, again, we're using GS1 and the Global Trade Item Number. You can access this from the Department of Health, Food and Drug Association. For the list of licensed embalmers, this is available from the Department of Health, Health Human Resource Development Bureau. For massage therapists, the same. For map coordinates, the standard is World Geodetic System, version 84, issued latest 2004. This is maintained by the United States Department of Defense, and this is available on the web. For medical imaging and communication, the standard is Digital Imaging and Communications Medicine or DICOM version 2011. This is maintained by the National Electrical Manufacturers Association. For medical laboratory results and clinical observations, the standard is LOINC or Logical Observations Identifiers, Names and Codes version 2.36. This is developed and maintained by Reagan Street Institute in Indianapolis, Indiana. And this is free downloadable as well. For medical, surgical, and diagnostic procedures, CPT or Current Procedural Terminology version 2011 is what we are using. This is part also of the electronic claims data requirements. For the registered drugs or medicines in the Philippines, the FDA issues a DOH drug and medicine identifier. It is part of the drug coding module, version 3 of the DOH electronic drug price monitoring system. Okay, so we get more complex here and technical, but these are all international standards. So, and these are freely available. You can download them on the internet. You can show them to your IT department, or you can ask your EMR vendors or hospital information systems vendors if they are capable of producing these standards or complying to the standards. One of them is the Cross Enterprise Document Sharing or XDS.B. This is available at the www.ihe.net. This is an international group called Integrating the Healthcare Enterprise. So this profile is like a recipe of how a document from one health facility can be exchanged to another health facility. That's called the XDS. Another would be the CSD or Care Services Delivery. Maybe you'd like to find out where Dr. So-and-so practices cardiology. The Care Services Delivery would be the one to tell us how to do that. So again, this is available from the Integrating the Healthcare Enterprise from www.ihe.net. If we make this profile work, we can actually know where is the nearest cardiologist or where is the nearest anesthesiologist given a certain geographical location. The other standards are Patient Identity Cross-Reference or PIX. Again, you can download this from IHE. It allows you to reference a patient. For example, in PGH, I am a patient there with number 123, and then in St. Luke's, I am a patient there, but my number there is 456. PIX would be able to do the matching of my record, which is an important requirement before we actually share any documents between two facilities. These are all standards and profiles that are already available. I think having them listed here is a very important first step I won't be surprised if many of us are not yet able to meet these standards like XDX, PICS, and PDQ. But at least we now have a reference document and we can strive to understand them and comply with them. The NHDD, I've mentioned about this. If you go to nhdd.gov.ph, you will be able to see a login page. Just make a request for a username, and once you get your username, you can access them. Maybe the participants in the call right now can tell us more about any updates on access. If you want to exchange a message between facilities, there is an international standard called Health Level 7 or HL7, Fast Health Interoperable Resources. This is a free standard. It's available on the internet. If the hospitals and health facilities follow this, they will be able to exchange information with each other more accurately.
Thank you, Dr. Alvin. So for the next part of our webinar, may we now call on Dr. Johari Hamoy.
Thank you, Cha, and also good morning to all. I would like to share our experience regarding what Dr. Marcelo mentioned. Good day to all. So I'm Dr. Harry Hamoy. So I am going to talk about our project. I'm going to share our experience regarding how to do this or how we did it, the standardized data, how we submitted it to the DOH, and how we did a workshop. Okay, so our project is titled Monitoring the Chronic Viral Hepatitis Treatment Cascade Through Electronic Medical Records. So we follow the WHO monitoring evaluation framework, the cascade of care. So that's what I did. That's what we did. And then this is the project overview. So actually, it was really to support the Department of Health, obtain timely and accurate and standardized data on chronic hepatitis B and C treatment cascade from electronic medical records. So by that, we wanted to include as many EMRs as possible here in the Philippines. Actually, right now there are 17 accredited EMRs in the country. And then from there, our objectives was, of course, to obtain the expert consents to the terms, to populate terminal surveys, the governance part also, we need to do that. Engage the EMR providers, also the private EMR providers, not just iClinicSys, which is the government EMR system. And then assist DOH in collecting standardized data from these EMRs. Okay, so basically this is sort of like a picture of what we want to happen. So from the different EMRs, so we will develop this terminology service for hepatitis, and then from there obtain an unambiguous shared meaning of hepatitis B. So it's just an example for the decision makers, the policy makers, for them to use this data in order to improve the situation, in terms of hepatitis, chronic viral hepatitis management in the country. So what's very important, I'm going to show you here, because this happened during the time of the pandemic. So we had several virtual meetings just to introduce the project, just to introduce the initiative. So here you can see a virtual meeting with the Department of Health, and of course the very important Hepatology Society of the Philippines, who's really involved in hepatitis, the hepatitis program in the country. And then we found out that the Department of Health is using this one, especially the hepatitis program. They have these two forms, that they already have, and they're using this in their pilot implementation site. So we decided we're going to use this as a template, as a basis for the workshop. So I'm just gonna show you how we did it. It was actually, we were very conscious, not to really make it very, very long. So it was just a 3 to 5 event. So we started with, of course, introduction of the viral hepatitis program, the global response given by WHO, the national program for hepatitis given by Dr. Magturo from the hepatitis program. And then, of course, the value of standards, which are very important, given by Ms. Sherry Estaban Bekemitz, and then the National Viral Hepatitis Surveillance System, which we have right now, and then the brief project summary. And then the workshop, what we did, we used the forms, like I mentioned, and then we made 3 breakout sessions, no, in order to get the consensus of the experts. We actually invited really several experts from WHO, DOH, Pathology Society of the Philippines, and even PhilHealth, no, part of DOH. And then we divided into three so that to really make good use of our time. Actually, we found out that 2 hours was actually not enough, no. But this is like how we organized it. For example, for this antigen, hepatitis B antigen. So we showed this to the different to the experts, and then there was a facilitator, and then we sort of like voted. No, we decided like a consensus, no, for this one based on the forms. So we had these recommendations, and then just pictures of the workshop, and then this was the output of the workshop. So in terms of the different fields for these forms, these 2 forms, there were 125 in total. So consensus was arrived in 87 fields, and then there were minor comments for 15, different suggestions for 17, and we actually were not able to review six of uh, 6 of the fields there. So we had actually another workshop to finish it. So to really make sure that there's consensus, no, majority or all of these components of the forms. So so this is the output. This was the output, and then 125 fields. So actually, it's a lot of pages, no. And then you have here the different elements, and this is an example of a case report form for this specific parts of the form. So you see here the elements, code system, file element, format, value set, and then this is actually the form, the organized form that we gave to DOH, specifically Epidemiology Bureau, and then from there they because we actually really worked with them also, and then from there we submitted the information, the data to KMITS, Knowledge Management Information Technology Service. And then from what Dr. Marcelo mentioned, no, so we actually officially the document was officially received on November 11, and then hopefully by around first week of December, so we'll get a response, and then there's an appeal or other actions. It will be the very specific 45 days, 2 hours and 5 minutes, no, for the DOH to respond, or for KMIS to respond to our request. So that's our experience. Now, I'd just like to highlight, no, it's very, very important, the governance part of this one, no, that DOH, WHO, and Hepatology Society of the Philippines is already involved in this early on, so that when we organize the workshop, the consensus workshop, to get the standardized terms, no, for hepatitis, chronic viral hepatitis, they're there already, and then during the workshop, these different stakeholders are also present, and we're really involved in the development of the consensus. And when we were able to develop this consensus, so we submitted it to KMITS, and then hopefully in 25 days, so we'll have a response. Well, in 45 days, no, to complete the response. So actually, that's our experience. And with this project, of course, part of this also, Dr. Janus Ong and Dr. Marcel is also helping us on this one. John Herb, Michael Herber, And then Joy and Jonel, also part of the team. That's it. So, questions from the group? Good afternoon, everyone.
Yes. Thank you, Dr. Harry. Good afternoon, everybody. I'm Dr. Portia Fernandez Marcelo. I'm taking over as your moderator. So we thank Dr. Harry Hamoy and his research team for sharing with you how the team actually tried to implement the process that the standards and the process how the processes that they went through as a model, perhaps for other advocates to standardize terminologies for the Philippine healthcare system. Are there questions? Maybe you can raise your hand, or in the meantime, while we're waiting for the others, maybe Dr. Harry, can you also share about funding in a way? What was the motivation for this research that you undertook?
Oh, actually, because of the advocacy, to have this standard data, it's very important for interoperability. And then, of course, when we actually, this is like when we talked about this, I think there was a when the pilot hepatitis program was developed, no, para they need it was mentioned there in the. I was not in the conference, but it was really mentioned, and it was highlighted that it's very important that we develop these standards. So we actually, that was the motivation, and then it was actually also not so easy to get funds for this one. So we had to actually have a private funding agency was also involved in hepatitis treatment, no, to really fund for this one. So there. So in terms, there's a question here. Was this work inspired by lessons learned from previous campaigns on hepatitis? Which one? So actually, I'm not so sure, no, about the previous campaigns, but I think we are the first in terms of really developing, making sure that these standards are developed, no, specifically for hepatitis. And then hopefully we documented this well. We submitted our reports, no, the documentation to DOH, and then hopefully others will follow also in terms of what we did. But of course, there were challenges, the workshops, no, and then of course the pandemic was actually hard to organize this one, especially if it's just virtual. The original Dr. Portia was face to face in a really nice place to do the workshop, no? But with this one, it was just virtual. It was really challenging, but yeah, there.
Good afternoon to everyone. Again, thank you to Dr. Marcelo, Dr. Harry Hamoy for this invitation to actually discuss with you these important things, which I only share with my students in the hope that we plant the seeds of the future. So, ang tanong ko po is related to yung kay Dr. Harry Hamoy, monitoring of chronic hepatitis treatment. Ano po yung, what do we envision in the future if we realize this? Ibig sabihin, if we implement this correctly. Do we see patients also being parang doing informed decision making together with their doctors? I am not too familiar with ang alam ko kasi chronic viral hepatitis can lead also to liver CA. I think it's a complication. So can we parang ano po yung nakikita natin walk through from a patient experience? Ano po yung nai-envision natin if this is realized already? Yung kumbaga sa rural health center po ba yung kaya po ba ito on that level? Or is this only possible kasi nga chronic yung baka inpatient on a level 3 level hospital lang po ba ito, or pwede rin sa primary healthcare setting? Yun lang po. Thank you.
Ayan. Hello, Doc Emmer. Yes. Sige. So actually in terms of like really the long-term plans for this one, I'm sure the patient experience will also be improved, but for this project, for our experience, so the plan is really to to have that interoperability, to interoperate. No, for example, yes, the primary healthcare centers are RHU, they're involved. We really planned, no, we are planning to of course iClinic sees the EMR of DOH, WA, CHITS, no, the EMR of UP will be involved in this one to interoperate. And then really the plan, Doc Emmer, is, for example, if the patient came in a rural health unit somewhere in Laguna, and then that patient will be transferred to another center. So his or her information should be available, no? Or, and of course, it's very important also in terms of epidemiology, because one problem is that our terms different with different EMRs. There are different terms. So, and sometimes when the dashboard, if you have a monitoring dashboard, sometimes this information will be not counted as just one. For example, one EMR will be using like hepatitis B. The other is like Hep B, just an example, Hep B. So if this appears in the dashboard, this will be like two patients already. So that's at least for this project, no, the primary goal is that one, to really standardize it. And then hopefully, if different EMRs will be part of this one. Actually, that's our dream, no, to invite as many EMRs as possible, the 17 accredited EMRs, no, to have this one standardize their data, so that when they share it to the DOH, the Department of Health, the data that we will be gathering, the data that DOH will be gathering, will be like the sort of close to to the real numbers, no? Those who are, of course, are going to these different health centers. But in terms of like the patient experience, Doc Emmer, I'm sure they have plans for that one, no? But I think it's also very important, because if you are interconnected, so the patient will be informed, and then of course the treatment, no, the treatment is very important, so that the DOH will know, okay, so there are like 10 million people with Hep B, and really sure that they have that. So in terms of getting these medicines, we don't have issues with are we going to buy just for 2 million because we don't know the exact numbers or something like that, no? That's the way we see it, Doc Emmer. So did I answer your question, sir?
Maraming salamat po. Okay, thank you, thank you. Thank you rin, Doc Portia.
Yes. Or Dr. Harry, can you please clarify if in fact you, as part of your project, was really not only to present it back to the DOH, but also to present the results to the EMRs, where the EMR providers
course,
currently. Yes. Has your project reached that point already?
Not yet, actually not yet.
Not yet.
So right now we just had our workshop, consensus workshop. So we'll be the next step will be to organize the EMR providers, no, to loop them in.
To loop them in.
Yes, yes po.
And therefore, Dr. Emmer, may I hazard a guess, so or hazard an answer, as the EMRs are really in a way very doctor or health provider centric. What can actually happen in the future as well, as long as the standards are there, then maybe the EMRs can extend into personal health records, where the patients are actually the ones controlling and understanding better their own health data. But that will require another process beyond what Dr. Harry has and his research team, Dr. Janus, my classmate, have initiated in this process, maybe. So that's part and parcel, I'm sure, of our entire vision for universal healthcare, where the patients are really front and center here.
There's a question from Dr. Agarwal. It reads, any pharmacy IHE profiles, and what is the most technologically marvel being used in pharmacy in the Philippines?
Okay. Hi, good afternoon, everyone. My name is John Michael Herber. I'm the data management officer from our project on the EMR and the chronic hepatitis reporting. So the technical aspects of our project, we utilized three standards, terminology standards. So the first one is ICD-11, and then Hello?
Yeah. Hi, greetings from India. So basically, I'm here having a chain of pharmacy stores, which is selling generic medicines. So I was trying to introduce FIRE principles and IHE profiles. So was just wondering if there's any tech pharmacy in Philippines which I can emulate here in India. I'm at Agra.
Thank you, Dr. Agarwal. So we're calling on Jan Michael Herber, who was the technical officer. So he's the data manager in this project that was presented by Dr. Hamoy. And then they will both perhaps answer your second question. So what can you recommend for the pharmacy? So let's, we'll call on Jan Michael Herber to respond. Thank you.
So hi, good afternoon. So to answer your question, unfortunately, we haven't implemented any sort of pharmacy IHE profiles yet. The coverage of our project is to utilize the viral case report form and the viral care form. We're using the FIRE profiles, particularly on patient information, encounter information, some observations, and the questionnaire profiles. We have not touched. Our main stakeholder on the side of the Department of Health is the Epidemiology Bureau. So the target is more of the surveillance part. So we were not able to touch on the pharmacy profiles, more of the surveillance aspect only of the monitoring.
Yeah, and I'd just like to add, Dr. Marcelo, Dr. Agarwal, I think in the country, so the pharmacies they're still not using it, and then but if they are, no, if we'll get information regarding that one, maybe chat will also share share Dr. Marcelo, no, because I'm not so sure if FIRE or these standards are being used already here in the country in terms of pharmacies, no, doing it.
So in fact, as far as the Philippines, I think is concerned, this is the first foray into a process.
Yes.
So maybe as a Dr. Agarwal, I hope you can glean lessons from this experience. So, and also for the Filipinos who are here, maybe that's also a process that we can actually reuse, and get the lessons from, so that when we engage the pharmacies as well in a unified health information system, this is how precisely we can use it over. Yeah.
I have one more question. There are three: open MRS, open EHR, and open MRS, open EMR, and open EHR. Which one of you think is more open source and scalable?
I will ask both Dr. Harry as well as Herber. Mr. Herber is an informatics practitioner. Go ahead.
To be honest, I have not I have no experience with any of those open source EMR solutions. I think Dr. Harry, I think one of Dr. Harry's project is based on Open MRS, if I'm not mistaken. But I personally have not looked into Open EMR and Open EHR, so I cannot answer on which is better on or scalable among those three solutions.
Yeah. Okay. Sige. Dr. Agarwal, actually, me also. I only experienced the Open MRS. So we're actually one of our EMRs that I'm involved in right now. No, we use the Open MRS. But in terms of the other two that you mentioned, so I don't have experience on that one. But in terms of scalability, so there, Dr. Marcelo, I can't really, sorry, Dr. Agarwal, I can't really answer your question accurately because my experience is only with Open MRS. And then in terms of scalability, well, in terms of systems, so we developed it in modular way. we were able to implement it, actually deploy it in around 300 rural health centers around the country. But it was, yeah, and then we did that like years back, like a couple of, almost a decade ago. So in terms of open MRS, so that was the dream, no, to really spread it to as many health facilities as possible, especially in rural health centers. But in terms of scalability, I cannot really expound because I cannot compare it with the open EMR or EHR.
Okay, final question on blockchain. Is it a good idea to start a project on blockchain chain, and with the ultimate objective being introduction of fire profiles and IHE profiles? Is blockchain equally interoperable with these standards?
Apologies again. I have no experience with blockchain. I mean, there were talks on moving towards blockchain, but I haven't heard the feasibility of using blockchain against fire profiles. So yeah, apologies. No, I have no exposure with blockchain yet.
And I think in the Philippines right now, I'm not so sure about this, but I think we haven't really used blockchain yet extensively in the health sector.
In the health sector.
Especially, yep, in the health sector. So in terms of experience, so there's not much to share regarding blockchain and the fire. Yep. So,
Okay. Thank you, Dr. So, Dr. Mayank, we have limited information on that, unfortunately. I will call on Mr. Martin Gomez. He has a question here for us, Yan. Mr. Martin?
Hi, good afternoon, everyone. Thank you so much. My name is Martin Gomez. I'm both with Dash Labs AI as well as the Philippine Red Cross. Just wanted to understand, in the discussion a while ago with the National Health Data Dictionary, right? I basically quickly Googled for it and found myself in a DOH subsite under UHMMISTRN DOH.gov.ph, and there's a registration page for NHDD, and it seems that it's just for government because it's asking for agency, department, something like that. So I was just wondering if this is also open for private institutions in order for us to understand what the requirements are. So that we can align towards the national thrust with respect to standardization of data.
okay. Okay. So actually, based on our experience, so with our project, we're funded by a private institution, and we're coming in actually not as well. We're part of UP Manila, but we are working together with the Hepatology Society of the Philippines, no, a private entity. Yes, a private entity. But Martin, what's important here is really to coordinate, to collaborate with this with DOH, specifically KMITS, the Knowledge Management Information Technology Service. Yep, to coordinate with them in order to be able to really know what's needed, what needs to be done. No? But I think, no, from what Dr. Alvin Marcelo mentioned, it's really possible. No? And then based on our experience, since we are sort of like an outsider, no, not really from DOH, so hopefully, well, we just submitted the data dictionary, yeah, the request. So just last November 11. So we'll see what will be the result of it. So hopefully it will be positive, and then we documented our what we did, no, so we can share it to the other organizations, groups, and maybe Martin also with your group, no, and how to do this, no, how DOH wants it to be done, no, in terms of really following the protocols, the process to achieve what's the objectives of interoperability.
Got it. Thank you so much for that input. So while waiting for while waiting for KMITs to get back to you with respect to your application, the best practice that you're doing right now is really to follow international interoperability standards such as HL7 and FIRE, right?
Yes, yes, yes.
Okay, got it. Thank you so much.
And then, of course, Martin, what's also very important is to develop or to have that consensus workshop. So that for in our case, it was hepatitis. So we convened, we gathered all the experts, hepatitis experts, epidemiology, and public health experts to talk about it, to have that consensus on what terms, the right terms to use, so that when we put it in the national standards data, we'll be using like all of the EMRs. Hopefully, no, all these EMRs will be using the same terms, no, same terms.
Understood. So just for just very quickly, just for additional context, right? Where we're coming from. We're actually coming from the lab side of things, from the pathology side of things.
Okay.
So clinical diagnostics, molecular laboratory. So right now our basis for at least for DOH reporting, right, is the ECIF. Thank you.
Dr. Harry, I thought you also involved some. Is that the Pathology Society of the Philippines?
Hepatology.
Hepatology.
Yeah,
Oh.
hepatology. Yeah,
Yeah.
hepatology.
Yes.
But for pathology, I think it's also very important, Martin, the units. Sometimes
Yes.
the unit is really, yeah, a big chunk of our discussion during the workshop for what units to use.
Yes.
No, what units to use to standardize that will really be a big help already.
Agree.
Maybe
Thank you so much.
Maybe Bear can also recount a little bit more that is relevant to the laboratories in terms of the standards, and the units, among others.
Yeah, there's I think Dr. Marcelo mentioned earlier the LOINC. I don't know the meaning.
Yes, correct. LOINC
Yeah.
is an entry standard for labs. Yes.
For
For labs.
laboratory. So as I mentioned earlier, the technical aspect, we've utilized 3 standard development organization dictionaries. So one is ICD, the second is SNOMED, and the third one is LOINC. So LOINC, we used LOINC particularly for laboratory observations because it's an international standard.
Got it. Thank you so much.
So the process is really instructive, actually, and I think it's extensible. The way you can extend it to certain conditions as well, to other conditions as well. So it's an exciting basis. Oh, there you go, Dr. Alvin. Maybe you can add.
So I heard a question about is the NHDD site just for public groups? The answer is no. It's supposed to be for everyone. So please submit a request for an access account. If you are having problems, please email me. I'll try to find a way to get your account approved.
Thank you so much, Sir Doc Harry. We can email Doc Alvin though.
Yeah, well. Yes. And then Dr. Alvin, actually, Dr. Agarwal had several questions that maybe you can answer regarding interoperability of blockchain and FIRE. And then if there are, the other question was if there are pharmacies.
Pharmacy profiles for IHE in the Philippines.
In the Philippines that they can use because, yes.
The current list right now, as I presented earlier on, are only PIX, PDQ, and XDS. So they still don't have the IHE profiles, the medication profiles. But you can see the trend. You can see the trend that the Department of Health is opening up to all of these international standards organizations. So I don't think it will hurt if you start, doing some advanced studies on the IHE profiles for pharmacy. I think it will help if you know all of these profiles already. On the aspect of blockchain, I think blockchain has an important role, but right now I think we need to get as many stakeholders leveled off on the minimum so that no one's left behind. I would encourage researchers to do research on blockchain. I think we should do this. But to ask blockchain for everyone, until we have a leading group leading the blockchain research, I think it will be difficult to pull in all the other participants. So let's level off on a common blueprint with the building blocks of standards that are inside that blueprint. And then hopefully some of the research institutions will band together and think about how to do blockchain with electronic medical records. Once they have that written up in a manual of operations, maybe they can show it to the Department of Health through the process that Dr. Hari presented, and then maybe they will adopt it. I think the point is have civil society now and academics supporting the DOH because they cannot do everything all by themselves. They should do regulation, they should do policy formulation, but I think they still need help with technology and research. Over.
I think there's a question from Dr. Brian Ferry, Dr. Portia.
Go ahead.
It reads, our NHDD registration is still pending. When can we access the data dictionary?
Okay. Please email me. I will try to get that opened up.
Facilitate, yeah.
Thank you. I don't own it, but I think I take responsibility because I showed you the circular. The circular showed the URL, so I'll take responsibility to finding out how you can get access to it. On the other hand, I think if you agree with me, I'll just suggest to DOH to just keep it open. No need for a username and password. Anyway, a standard is only as good as whoever has access to the standard. Over.
Indeed.
Do you agree? Raise your hand if you agree that we will just request DOH to remove the username and password. Okay, thank you. On the question of Mayank on the list of 17 accredited EMRs, when I was the PhilHealth CIO in 2012, there were, I think, more than 17. But the accreditation process is the one that I'm not familiar with. So again, that's on my plate. I will get that list from DOH. But maybe Hari, do you know that?
As Pivotal, yeah. How many are EMR providers?
Well, the 17, they are the accredited based on the information, sir. Based on the online information, what's available online. It's really 17 right now.
Are these only for primary care facilities or including the ones
including
for the
hospitals? Yeah,
including
hospitals.
All right.
Dr. Faraon has a question. Dr. Portia.
Go ahead, Emmer.
Okay po. Good afternoon po uli. Bali po, I again went to the KMIT's website. I came across similar AO, I think it's 2013, circa Secretary Ona, -0025. Sabi niya doon is a national implementation of health data standards for e-health standardization and interoperability. In what way po yung ano lang, for contextualization lang, how does yung piniresent po na circular ni Doc Eloy earlier sit with the e-health? Tapos yung kasing e-health, I saw the strategic plan 2014 to 2020. So I think by 2020 dapat realize na because no one probably saw COVID coming, and COVID is I think 2020 na eh. So I think we would have been better prepared with surveillance, alam niyo na, contact tracing, if we had this before. Kaya nga lang, yun lang yung ano ko, paano siya mako-contextualize with that, and is there going to be any adjustments at all? Yun lang po. Thank you.
Thank you, Dr. Emmer, for the question. Maybe some historical perspective because I was part of that group in 2013, 2014 when the governance structure was created. The goal then was interoperability through a platform called the Philippine Health Information Exchange. So the Philippine Health Information Exchange contained, in the document that I showed you, those would be the standards that would be part of the Philippine Health Information Exchange. There was a budget that came with it. It was proposed. Unfortunately, the budget was not consumed. So essentially, the Philippine Health Information Exchange could not be invested on. So it was just something on paper. Nevertheless, PhilHealth took it on and basically said, we will use and we will call it PHIE Lite. And PHIE Lite is essentially a limited implementation of the Philippine Health Information Exchange, which is what we have right now. Today, interoperability is happening. Why? Because St. Luke's and PGH, we have different electronic medical records, but we are able to send the same electronic claims to PhilHealth. That's exchange. That's exchange. Medical City, Asian Hospital, different electronic medical records, but following the standard of electronic claims, you are able to send. In St. Luke's, we send hundreds every day to PhilHealth. I'm sure in total SPMC would be the number one. They have a lot of electronic claims that are being sent. If you really look at it, that's interoperability, because before you would have to write that down on paper claims, CF1, CF2, CF3, and then send that over to PhilHealth, and then you'll wait for forever because they need to encode the paper CF1, CF2, CF3 into their electronic claim system. But now, because of the XML exchange between the hospitals and PhilHealth, they're able to get these claims on a much faster way. I think it's choking. Actually, the speed is actually choking already the PhilHealth system. And yeah, so in a way, it's good because there is a standard. It was issued by PhilHealth. They even increased it to CF4. I'm sure many in the audience would have challenges that they have already solved with their CF4, but there's a lot of data actually in the electronic claim system. Question, could we have used the CF4 system in PhilHealth for COVID monitoring? Theoretically, I think yes. But no one thought about doing that. We did the CDRS, which is, like get the CIF submitted to DOH and then get the lab results on a daily basis, which is important. Those are important. But I think there's also COVID data in the electronic claims, which is sent religiously by all hospitals, or else they will not be paid their reimbursement. So the PHIE was designed in 2013. It was implemented on a light basis, only between hospital and
PhilHealth.
But as a matter of fact, all you need to do is just create that regulatory environment where, St. Luke's, you have to send that same e-claims to PGH if the patient transfers to PGH, okay? We will do that. If it's a matter of regulation, it's the same file. And I think PGH will be able to understand it because they're able to do electronic claim submission as well. So I think what's missing is governance. Like just tell us what's the vision, and then how do you make that vision into an operational model, and then the hospitals will follow. Of course, I'm afraid of the digital divide because St. Luke's and PGH have resources that other hospitals and that facilities don't have. So PSDH is very conscious about that. While we're pushing all of these technologies, we shouldn't forget that 80 to 90% of the countries do not have the resources as St. Luke's and PGH. So we need to make sure that all of these efficiencies and improvements will benefit not just the big hospitals, but also everyone. Thank you.
Sir, yung governance, DOH ba yan?
The governance is the National eHealth Governance Steering Committee led by the Secretary of Health. The co-chair is the Secretary of ICT because there are technology components in eHealth that are beyond the resources of the Department of Health. But if they work together, I think, and the drawing is already there, way back in 2014. I think it's just a matter of, the leaders telling us, we want you to implement the PHIE in full, but prioritize maternal mortality, infant mortality, and
public health.
But that needs to come from them. I mean, I'm just second guessing. I'm not the secretary.
Okay, sir. Thank you, sir. Thank you, sir. Malinaw na, sir. Maraming salamat.
Maybe also, in addition to that, that was the context then, but the motivation, remember, was really to put down those infrastructure like the HIE, the PHIE that hasn't yet happened. However, the standards were missing. That's why the AO had to come out, and all of the current things that Dr. Alvin actually presented were recent in that sense. So it's an updated version of the standards that they were that the eHealth governance group has been reviewing. So now it's more publicly available, and the intent is really to make it more popular. And hopefully, Dr. Martin Gomez's group will really find its use, and much other groups as well. So in terms of timing, yes.
Thank you po.
Okay. I think we still have maybe one more question or a comment from the group. We are happy to have non-Filipino participants, because this is really part of the bigger International Digital Health Week.
Dr. Portia.
Yes. Go ahead, Dr.
I don't call her Dr. Portia. I'm so okay. So thank you very much for joining this session. I think this digital health, we can do this, but we need to be together. It cannot be just government. It cannot just be private sector. It cannot be just those with access to technology. I think we need to share knowledge. There's a lot of knowledge in PGH, in St. Luke's Medical City, the e-claims providers, the electronic medical record users of cheats, the vendors who are offering commercial EMR. There's a lot of knowledge. And so PSDH, we formed it so that we can, come together regularly, share knowledge. Only if you're willing to share your knowledge, share battle scars, inform the others. Okay, don't do that. I went there. It didn't work. Do this instead. No, that's the context of AHIN. No? When we formed this in 2011, we all raised our shirts and we showed our battle scars. And then the other countries were saying, oh, I have a similar battle scar, but I was able to solve it this way. And so by pooling our knowledge together, I think we can much more faster get digital health running to make UHC work. And I think we need to be always conscious, because of course all of us have access to Zoom. We have access to resources, but the people who are not in this call are actually those that need the most to understand what this is all about. I'm happy to have Mayank and Dr. Hori in the call. They're international, so we are forced to speak in English so that they can participate and understand. But I like the interest that they're giving. This is just the Philippines, but this is a model that other countries will follow. Tomorrow there will be a session by other countries like Thailand, Bhutan, and Laos, and they have their own specific issues as well. But according to AHIN, we need to come up with a method by which we can solve this. And the first one is governance. There needs to be leadership and ownership of the health sector vision and strategy. Once you have that vision and strategy coming from the top, then you interpret that into an architecture or the blueprint. And that's what the Philippine Health Information Exchange was all about. We drew that way back in 2013 and 2014. So what's missing with the PHIE? There was governance in 2013 and 2014. The structure was created. The roles were played out. There was a blueprint. We called it the Philippine Health Information Exchange. I think the next step is program management. In the blueprint, if you look at it, there are responsible agencies for each component of the PHIE. There's somebody responsible for the client registry, somebody responsible for the facility registry, somebody responsible for the health worker registry, and somebody responsible for the terminology service. Now, each of those agencies responsible for those key registries need to step up. They need to be invested on. They need to have program capabilities so that they can deliver those important registries. Because if one of those registries is not available and not accessible, then we can't complete the data structure, the data architecture. And then the next one will be the standards and interoperability. So we summarize in AHIN all of this into what we call the mind the gaps. G for governance, A for architecture, P for program management, and S for standards. I think the missing step right now, because we already have S, we talked about S today, the missing step is the P. the program management are people in the Philippines knowledgeable about how to read the blueprint and how to acquire or build their electronic medical record so that they're using the standards, so that if they use the standards, it will actually interoperate with PhilHealth, with DOH, and with each other. And we all know in UHC, it's not one way. Facility to PhilHealth will work because of reimbursement. Facility to DOH will work because of compliance. But that's not UHC. UHC is all about record portability, that the patient can have access to their records when they transfer to the other facility. And that's, I think, the greatest challenge that we face right now. How do we get this e-claim system exchanging not just facility to PhilHealth, but facility to facility? I think the technology is already there. What's missing is, can we actually do that? Won't we be sued for data privacy violation? Is there a mechanism to ensure that when we do that, we won't go to jail? Why did you share the data from one hospital to the other? What regulatory permission did you ask for? What regulatory permission did you obtain to allow you to exchange that very, very sensitive information from one facility to the other? I think that's the missing step right now. Of course, the other one is the infrastructure. And that's something that we cannot resolve in the health sector. We need the help of the ICT there. Thank you. I've talked too much.
Dr. Alvin, before closing, may we have one more question from Dr. Brian Ferry?
Sure.
Dr. Brian, would you like to speak through your microphone?
Hi, hello. Good afternoon. So, when will be the target date for at least the testing or dry run for this?
So for the electronic claims, of course, it depends on the hospital when they will be ready. When I was the PhilHealth CIO, there were 200 hospitals with electronic systems. That was way back in 2012. I think today there are many more hospitals with electronic systems. For those without electronic systems, we accredited health information technology providers that they can contract, so that, while if they don't have a lot of money or resources to purchase or build their electronic medical record, they can actually outsource and contract the electronic claim system to this health information technology provider. So as we speak, this interoperability is actually working at any moment. The question is, why are health facilities not yet in electronic claims? The first answer is obvious. They don't submit claims because they're not in the electronic claims system. Maybe they're primary health care, or they're a laboratory, or they're a pharmacy. So there's no reimbursement yet to pharmacies and to laboratories. The second question is, they don't have the capability. And so that's why I think they need to know that there are actually service providers available that they can tap. The third is, they know these service providers, but they don't want to file a claim electronically, which is starting to become, very limited, because you lose out on a lot of the reimbursement and benefits of filing an electronic claim. So the e-claim system, which is again a very limited set of the Philippine Health Information Exchange, is already working. There's a larger interoperability that you can do once your electronic claims capable. Then it's just a matter of increasing the circle, so to speak, of what messages you can create and exchange with DOH and PhilHealth. And I hope that DOH and PhilHealth can start giving us these new messages, not just the electronic claims for reimbursement purposes, but starting to have electronic hepatitis reporting, electronic myocarditis reporting, electronic TB reporting, or integrating them together in a common format, so that you don't have to log into different DOH systems. Just from your EMR, push it to DOH, and when they get it to DOH, they will be the one to just route it to the appropriate vertical program that needs that data. I think this is doable, but then again, it requires orchestration and very strong governance and a clear blueprint.
Yes, I think that's our last question for this session, Dr. Alvin. So we would like to thank Dr. Alvin and Dr. Harry for sharing their time, their expertise, and their experiences, as well as to Dr. Portia and Sir Herbert for helping drive the discussion, and to our participants for actively participating in this session.